You were there?
Yeah.
يعني من اليمين للشمال يبقى مثلا 2 8 6 2 8
صفر 4
6 4 6 وتلاقي شوية
غريب أوي والله.
يعني أنا مش خالص
Hello, we are starting our revision. It will be a rapid revision, and we are starting with anatomy. Hello, Dr. Isra.
Yes, we can start.
Yeah, we can start. Hello.
Yes.
You can see the screen.
Yeah.
Okay. Okay. RDA, neck and shoulder injury. Okay. No, you already joined. You wrote some message.
No, I want to open from laptop.
Yeah, I think code. The same link you can copy and you can try to open it from there.
It's right, but he asked for join for enter join.
Okay, I'm checking. Yeah, joining code one meeting ID. You can put this meeting ID.
Yeah. Okay, we can start. I will try another time. Can start?
I gave you. You can see.
Hmm?
I put the meeting ID and passcode. You can put it in from laptop. It will join.
Okay. We can stop.
Okay. Patient involved in road traffic injury. Okay. So this is the stem. Now you are there. You are on the screen.
Mm-hmm.
Okay.
But
So
rapid.
what injury do you suspect? This is brachial plexus injury. What injury do you suspect? Brachial plexus injury. It is as like mechanism of injury, traction injury. Common trunk to be injured, upper trunk. C5's nerve will exit in between which two vertebrae? Between cervical 4 and cervical 5. Then where do uh, they exit? Where do they exit? They exit from intervertebral foramen. Point at the vertebra. You will be given a vertebra in the exam. Okay, they exit from the intervertebral foramen. C5 and C6 cutaneous supply on the human body. C5 on the lateral arm and C5 on the lateral arm and C6 lateral forearm and the thumb. C5 lateral arm, C6 lateral forearm and the thumb. Describe Erb's palsy and Klumpig's palsy. Erb's palsy due to damage to the upper nerve root, cervical 5-6, and motor affection, waiter tips deformity, paralysis of the arm, abductors, so arm will be adducted, paralysis of the arm, external rotators, arm will be internally rotated, paralysis of the forearm flexors and supinators, so forearm will be extended and pronated, and sensory affection will be mm, loss of sensation of radial side of the arm and forearm. Radial side of the arm and forearm. Okay. And the Erb's palsy, motor affection and sensory affection. Okay. Now Klumpig's palsy. Klumpig's palsy, injury to the lower trunk, cervical 8, thoracic 1. Klumpig's palsy, uh, lower trunk, cervical 8, thoracic 1. Motor affection, claw hand deformity. Claw hand deformity, what will happen? Paralysis of the all intrinsic muscle of the hand, paralysis of the wrist flexors. So, okay, paralysis of the all intrinsic muscle of the hand, paralysis of the wrist flexors, and hyperextension of the metacarpophalangeal joint, and loss of sensation over the ulnar border of the forearm and hand, both side. Arm in Erb's palsy, sensory affection was only in the arm and forearm, arm and forearm, arm and forearm. Erb's palsy, arm and forearm. But Klumpig's palsy as intrinsic muscle of the hand, hand related. So Klumpig's palsy will be loss of sensation over the ulnar border of the forearm and hand. Here we have forearm and hand. Okay. Hmm. This is Lahore, but Lahore, it is not for you. It is not for Cairo.
It
Okay,
that on my Gmail
it's okay.
message on Gmail.
It's okay. No, no. They will update you in different time when exam.
They
Say,
means
from
they means that they
Royal
will
College. Royal College.
they just informing me that they will update me or
Yes.
that
No, no, no. They whenever
uh,
any exam center opens anywhere under them, they will update you.
mm,
Okay. Identify rotator cuff muscle origin, insertion, and nerve supply. Rotator cuff muscle, we have supraspinatus, infraspinatus, infraspinatus, teres minor, and last we say about subscapularis. So supraspinatus originates from supraspinous fossa, infraspinatus fossa, and teres minor from dorsolateral aspect of the scapula. Supraspinatus, infraspinatus, and teres minor all are inserted into greater tuberosity of the humerus. Greater tuberosity of the humerus. And supraspinatus, infraspinatus, they are supplied by suprascapular nerve. Supraspinatus, infraspinatus are innervated by suprascapular nerve, teres minor by axillary nerve. Now, subscapularis from subscapular fossa. It inserts into lesser trochanter of humerus. Lesser trochanter of humerus, and it is innervated by upper and lower subscapular nerve. What is deltoid muscle? What is the deltoid muscle origin and insertion? Deltoid muscle origin, lateral clavicle and scapula, and insertion, deltoid tuberosity of the humerus. Yes, deltoid muscle origin, lateral clavicle and the scapula, and insertion in the deltoid tuberosity of the humerus. How to test it on actor? How to test it on actor? Uh, okay, inability to abduct the shoulder above 15 degree and loss of sensation over the badge area. What are the flexors of the elbow and their nerve supply and the value? Name of the nerve in the forearm. Okay. Flexors of the elbow. Flexors of the elbow are brachialis, biceps, biceps brachii. Where is brachioradialis? Only there was five, but it is reduced only two. Good.
eh?
We studied this one total five muscle: brachialis, biceps brachii, brachioradialis, uh, then frontoteres. Anyway, you can see. So brachialis, origin, everything. What are the flexors of the elbow and their nerve supply? Brachialis, anterior humerus origin and insertion into ulnar tuberosity, and action is flexing forearm and innervated by brachialis by radial and musculocutaneous. Radial root value cervical 5 to thoracic 1 and musculocutaneous cervical 5 to cervical 7. Biceps brachii musculocutaneous. Biceps brachii purely musculocutaneous. It is from cervical 5 to cervical 7. Only they are asking about the nerve supply with the value and name of nerve in the forearm. Okay, another one. And pronotor teres. Pronotor teres. Pronotor teres. It is also by median nerve. Hmm. Name the sensory nerve in the forearm. It is lateral cutaneous nerve of forearm. Show on a actor reflex of biceps, triceps, and supinator. We have to demonstrate it. What is the sensory distribution of the radial and median and ulnar nerve? Okay, radial nerve, posterior forearm, lateral two-third of the dorsum of the hand, and posterior aspect of the lateral finger, lateral 3.5 finger. Posterior forearm, lateral two-third of the dorsum of the hand, and posterior aspect of the lateral 3.5 finger. Now median nerve, lateral two-third of the palm of the hand, lateral 3.5 digits on the palmar side, and tip, dorsum of the tip of the index, middle, and thumb. Now ulnar nerve, medial one-third of the palm and dorsal aspect of the hand and finger. Okay.
Mm-hmm.
Rotators of the scapula, upward rotators of the scapula. We have upward rotator, trapezius and serratus anterior, downward rotator, rhomboid major, minor, and levator scapulae. Origin. Here we have to read origin, insertion, and nerve supply. So origin, trapezius, trapezius from spinous process cervical 7 to thoracic 12. Mhm. There was other things, but here they removed those, right? Before we studied
Remove.
superior nuchal line, occipital protuberance,
Yes.
but
Yes.
they removed those things. So trapezius,
Mm.
this is good. If they accept this answer, means it is good. So trapezius from superior spinous process of cervical 7 to thoracic 12. Insertion to clavicle and scapula and acromion. Clavicle, scapula, and acromion. Okay. And action, trapezius, rotating scapula. Rotating scapula. Action also they asked or no? Origin, insertion, and nerve supply. Action on it. Origin, insertion, and nerve supply. And innervation by trapezius by cranial nerve 11. Insertion, clavicle, scapula, and acromion. Origin, spinous process, cervical 7 to thoracic 1. Now serratus anterior, upper ninth rib from 1 to 9, insertion into serratus anterior into ventral, in inner aspect of the scapula, inner side, ventral and medial side, scapula, ventral, medial border, and action preventing weaning by long thoracic nerve of bell. Then latissimus dorsi. Latissimus dorsi. Why latissimus dorsi? Trapezius, serratus anterior, rhomboid major, minor, and levator. Rhomboid major and minor. Latissimus dorsi is not here. levator, yeah. Rhomboid minor from uh, rhomboid minor from spinous process of cervical 7 to thoracic 1, and it inserts into scapular medial border, scapular medial spine. Okay, and it is by dorsal scapular nerve, both rhomboid major minor both by dorsal scapular nerve. Trapezius serratus anterior, rhomboid major minor, and levator scapulae. Levator scapulae, rhomboid minor. Okay, rhomboid minor from thoracic spinous process of thoracic 12 to thoracic 2 to thoracic 5. This is major. First minor from C7 to T1, and major from T2 to T5, and it inserts into scapular medial border, dorsal surface. Because in ventral surface only serratus anterior, whole ventral surface by serratus anterior, and dorsal surface by these three: levator scapulae, rhomboid major, minor. Levator scapulae will remain in the upper part, tip. So, it, levator scapulae originates from transverse process of cervical 1 to cervical 4. Cervical 1 to cervical 4. That's okay. And it inserts into scapula superior medial, innervated by, this is also dorsal scapular, but specifically C4, C3. Okay. Brachioradialis muscle, demonstrate on yourself action. Brachioradialis muscle, demon- demonstrate action on yourself. Mm, flex forearm, flex forearm, and flex forearm, and it is innervated by radial nerve. Brachioradialis, flex forearm, and innervated by radial nerve. Show C5 reflex, it is bicep reflex. Name three muscles supplied by musculocutaneous nerve and root veru. BBC is bicep brachii, brachialis, and coracobrachialis. Root veru cervical 5, 6, 7. External rotator of the forearm. External rotator, the attachment in the greater trochanter. This is supraspinatus, infraspinatus, and teres minor. Then axillary, axillary nerve cutaneous supply, axillary skin to the lower half of the deltoid. Skin to the lower half of the deltoid. Skin to the lower half of the deltoid. This is the axillary supply. Axillary nerve muscle, axillary nerve muscle supply, deltoid and teres minor. Shoulder abductor muscle, supraspinatus 0 to 15 degree, deltoid medial fibers 15 to 90 degree, trapezius and serratus anterior over 90 degree, which will require upward rotation of the scapula with lateral rotation of the humerus. Okay. Okay. First station finish. Now station 2. Okay. Station 2, stomach, pancreas, and duodenum. Identify structure number 2. Structure number 2, this is the body of the, hello,
Yes.
I cannot see. Are you there?
You stop the sharing. Yes, I am here. Hello?
Yes, yes. Hello.
Mhm. Yes, I read message.
Okay. Blood body of the stomach. Structure number 2. Identify parts of the stomach. Fundus, number 6. Fundus is number 6. Where is fundus? Okay. This is fundus, number 6. Then fundus body, number 2. Pyloric antrum, number 18. And pyloric canal, 19. Yesterday we studied fundus body, pyloric antrum, number 18. Pyloric canal, number 19. Okay. Blood supply of the stomach. Arterial supply in the laser curvature, left gastric artery from celiac, left gastric artery from celiac trunk, hmm, right gastric artery from hepatic artery, greater curvature, left gastrocolic artery from splenic artery, right gastrocolic artery from gastroduodenal artery, gastroduodenal from hepatic artery, and fundus, short gastric artery from splenic artery, fundus from short gastric splenic artery. Now venous drainage, left gastric vein drain into splenic vein, right gastric vein also, sorry, portal vein, left gastric vein, left gastric vein into portal vein, right gastric vein also into portal vein, left gastroepiploic vein, splenic vein, short gastric vein, splenic vein, left gastroepiploic vein, splenic vein, short gastric vein, splenic vein, right gastric vein into superior mesenteric vein. Identify pancreas. Here number 19, 3, 9, and 16. This is all about the pancreas, where head of the pancreas is number 3, okay, the neck of the pancreas number 9, and tail of the pancreas number 16. Okay. Development of the pancreas. Pancreas developed from the hepatic ventral bud and dorsal bud. Ventral bud and dorsal bud. Ventral bud from hepatic diverticulum, and it give rise to the lower part of the head and unsealed process. Head, ventral bud. Ventral bud from the hepatic diverticulum, and it gives rise to the lower part of the head hepatic diverticulum, and it gave rise to lower part of the head and uncinate process. Lower part of the head and uncinate process, and dorsal bud. Hello, your two devices open together. That's why your two device was open. That's why.
Yeah. Okay. Now I can open Team. That's for the first time on laptop. Okay.
Okay, then can open.
Mm-hmm. Okay, you can continue.
Yes. Okay. Development of pancreas. Pancreas developed from ventral bud and dorsal bud. Ventral bud give rise to lower part of the head, lower part of the head, lower part of the head, and uncinate process. Lower part of the head and uncinate process. Okay, and dorsal bud, dorsal bud from dorsal aspect of the duodenum. Dorsal bud from dorsal aspect of the duodenum and give rise to upper part of the head, neck, body, and tail. Upper part of the head, neck, body, and tail. Okay. So development of the pancreas, we have ventral bud and dorsal bud. Ventral bud from the ventral bud from hepatic diverticulum and give rise to lower part of the head and uncinate process, and dorsal bud from dorsal aspect of the duodenum and give rise to upper part of the head, neck, body, and tail. Peritoneal relationship of the pancreas. Only tail is intraperitoneal. All are retroperitoneal. All is retroperitoneal except tail. Only tail is the intraperitoneal. All are retroperitoneal. Then blood supply of the pancreas. Blood supply of the pancreas. um, Superior pancreaticoduodenal artery supply. Superior pancreaticoduodenal artery from gastroduodenal artery. Gastroduodenal from which artery? Gastroduodenal.
Yes, so do you know? Hepatic?
Hmm. Superior pancreatic duodenal artery from gastroduodenal artery, then inferior pancreatic duodenal artery from superior mesenteric artery, and it supply head and uncinate process. Supply head and uncinate process. Inferior pancreatic duodenal artery, and pancreatic branches from the splenic artery, they supply tail and body. Pancreatic branches, they supply body and tail. Body and tail. Pancreatic branches mainly supply body and tail. So again, artery supply superior pancreatic duodenal artery from gastroduodenal artery, from hepatic artery. It supply head. Then Here they became very specific. Before it was not explained like this.
Because it
So uncinate process, say head and uncinate process. So this is uncinate process, head, you can say head. This is neck, neck not this much long. Neck, this is body and tail. So head supplied by superior pancreatic duodenal artery. Head, head. This is superior pancreatic duodenal artery. From gastroduodenal artery, head. Then inferior pancreatic duodenal artery from superior mesenteric artery supply head and uncinate process. Head and uncinate process, some part of the head and uncinate process, it will be supplied by again inferior pancreatico duodenal artery. Pancreatic branches from the splenic artery supply tail and body. Head, this is uncinate process, this is head, neck, body and tail. This body and tail both are supplied by splenic. Okay. Okay. So again, spleen arterial supply superior pancreatic duodenal artery from uh, gastroduodenal artery. It supply head. Then inferior pancreatic duodenal artery. It comes from superior mesenteric artery. It supply head and uncinate process. And splenic branches, pancreatic branches from splenic artery. It supply tail and body. Venous drainage, superior pancreatic duodenal vein, inferior pancreatic duodenal vein, and veins drains into the spleen. Superior pancreatic duodenal vein, inferior pancreatic duodenal vein, and veins drains to the splenic vein. The courses of the splenic artery.
you have to be more rapid.
Hmm. Courses of the splenic artery. Splenic artery. This is new question. Splenic artery. Splenic artery arises from the celiac. Splenic artery is left hand side. S is splenic artery. Arises from the splenic artery, then passes above the pancreas, behind the stomach, separated it separated from it by laser sac and renal ligament, and the ends by terminal branches in the splenic hilum. Again, splenic artery, it arises from the celiac trunk, then it passes celiac trunk passes above the pancreas. Splenic artery, it passes above the pancreas and behind the stomach. Above pancreas, behind the stomach, and it is separated by laser sac, and uh, then ends by terminal branches into the splenic hilum. Describe ductal drainage system of the pancreas. Main pancreatic duct or duct of Woodson. Duct of Woodson. Main pancreatic duct drain head, body, and tail. Head, body, and tail. Main pancreatic duct. Main pancreatic duct drain head, body, and tail. Opens into mesoduodenal papilla and accessory pancreatic duct, duct of Santorini. They drain the uncinate process, open into minor duodenal papilla. Vessels present behind body of the pancreas. So vessels present behind body of the pancreas, head, neck, body is a splenic vein, and behind neck is portal vein. and in between stomach and pancreas, laser sac. Peritoneal relation of the duodenum. First part of the duodenum lies within the peritoneum. First part of the duodenum lies within the peritoneum, but its other parts are retroperitoneal. Vessels present in the front and behind the third part of the duodenum. In the front, superior mesenteric artery and vein. Third part of the duodenum. Third part of the duodenum. In front, superior mesenteric artery and superior mesenteric vein. Behind, we have inferior vena cava, abdominal aorta, and right gonadal vein. And right gonadal vein. Right gonadal vein. Hepatic artery runs in which part of the peritoneum? Hepatic artery runs in which part of the peritoneum? Into lesser omentum. Into lesser omentum. Hepatic artery runs in which part of the peritoneum? Hepatic artery runs in lesser omentum. Shoulder and hip. Chapter 3. Muscles of the rotator cuff original insertion. Check neck and shoulder. Okay. Okay. Identify acromion. Acromion number 2. Uh, coracoid process number 3. What nerve related to spiral group? Radial nerve. What nerve related to spinal group? Radial nerve. Clinical picture of radial nerve injury. Clinical picture of radial nerve injury. What will happen? Radial nerve, radial nerve, radial nerve, radial group. So paralysis of the wrist, extensor wrist drop, paralysis of the fingers, extensor finger drop, and loss of sensation in the first wave space. So this is clinical picture of radial nerve injury at spiral group. Why patient with radial nerve injury will have weak power grip. The radial nerve supply extensors of the wrist and this gives synergistic effect of the power grip. Radial nerve supply extensor of the wrist and this gives synergistic effect of the power grip. Identify medial condyle number 7. Extra.
Yes.
This is namaz.
Yes.
You have to go for iftar.
No. There is another 15 minutes.
Hmm. Okay. 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 Why patient with red? Okay. Identify medial condyle. Medial condyle number 7. From the front, you can just have a look. I think no need this thing. Nerve related to medial condyle. Medial condyle. It will be ulnar nerve. Nerve injury, sensory and motor. If ulnar nerve injury, there will be ulnar paradox. Claw hand with ulnar paradox. Claw hand with ulnar paradox. Claw hand with ulnar paradox. Sensory, okay. Ulnar nerve injury will have claw hand with ulnar paradox, and sensory loss of sensation of the ulnar nerve. So ulnar nerve, ulnar nerve, ulnar nerve, ulnar nerve. Loss of sensation of the medial one third of the palmar and dorsal aspect of the hand and finger. Loss of sensation of the medial one third of the palmar and dorsal aspect of the hand and finger. Medial one third of the loss of sensation. Loss of sensation of the medial one third of the loss of sensation of the medial one third of the palmar and dorsal aspect of the hand and finger. Hip flexors, hip flexors, hip flexors and insertion. Hip flexors, yes, hip flexors, hip joint flexor. In the anterior compartment, we have iliacus, psoas major, and rectus femoris. Rectus femoris, iliacus, psoas major, and rectus femoris. All muscles inserts into lesser trochanter of the femur. Hip flexors, iliacus, psoas major, Psoas major and rectus femoris. Iliacus psoas major and rectus femoris. Iliacus psoas major and rectus femoris. Iliacus psoas major and rectus femoris. Okay. Identify anterior superior iliac spine. Number 5. Nerve passing medial to it is lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh, root value. Lateral cutaneous nerve of thigh, lateral femoral cutaneous nerve. Same thing, lateral cutaneous nerve thigh or lateral femoral cutaneous. It is number 2. Number 3. Condition caused by its compression melalgia paresthetica muscles attached to anterior superior iliac spine. Yes, it is sartorius origin and tensor fascia lata also origin. This is new question. Which muscle attached here? Sartorius and tensor fascia lata originates from here. Sartorius and tensor fascia lata. Sartorius and tensor fascia lata. Sartorius and tensor fascia lata originates from here. Sartorius and tensor fascia lata originates from here. Identify pubic tubercle. It will be 24. This is 24 for pubic tubercle. 24 pubic tubercle. 24. It is pubic tubercle. Identify pubic tubercle 24. Pubic tubercle 24. Okay. Origin and insertion of the gluteus medius. Gluteus medius. It will be here. 21 is posterior gluteal line and this is anterior gluteal line. In between this, origin and insertion of gluteus medius. Origin ilium between the anterior and posterior. What? Anterior posterior gluteal line. Origin between anterior and posterior gluteal line and insertion greater trochanter of femur gluteal lines. Again, insertion greater trochanter of the femur and gluteal line. Insertion greater trochanter of the femur and gluteal line. Okay. Then what is the function during walking? Supports the body when walking and prevent the pelvis from dropping to the opposite side. Supports the body when walking. Supports the body when walking and prevents the dropping of the pelvis. Prevents the dropping of the pelvis to opposite side while one leg is on the ear. Support the body when walking. Support the body when walking and prevent the pelvis from dropping to the opposite side. And prevent the pelvis from dropping to the opposite side. What are the main flexors of the hip? What are the main flexors of the hip? Same, iliacus, psoas major, and rectus femoris. Iliacus, psoas major, and rectus femoris. Main flexors of the hip. Okay, where it is inserted, laser trochanter of the femur. What is the origin and insertion of the quadratus femoris? Quadratus femoris. Origin from ischial tuberosity. Quadratus femoris. Origin from ischial tuberosity. This is for quadratus femoris from ischial tuberosity and insertion into intertrochantary crest of the femur. Quadratus femoris, very important. Quadratus femoris, it originates from ischial tuberosity, big space. Quadratus femoris, it originates from ischial tuberosity and insertion into intertrochantary crest of the femur. Intertrochantary crest of femur. Station 4, ankle under foot. Name of the tarsal bones. This is calcaneum, talus, cuboid, navicular, cuneiform, fast metatarsal, phalanges. Articulation, talus articulates. We have started this one yesterday. Name this marked structure. Muscle inserted. Diversity of the fifth. Name this marked structure muscle inserted. Tuberosity of the base of the fifth metatarsal muscle is peroneus brevis. Tuberosity of the base of the fifth metatarsal. So where is the mark? I cannot see the mark. Is this? This is the mark? Maybe. Maybe this is the mark. Tuberosity of the base of the fifth metatarsal. Tuberosity of the base of the fifth metatarsal inserts peroneus brevis. What will happen in case of fracture of mid-tarsal bone?
Mid-talus. Mid-talus bone, avascular necrosis.
Hmm. What will happen in case of fracture of the mid-talus bone? Mid-talus will undergo avascular necrosis. What will happen in case of fracture of the mid-talus bone? Avascular necrosis. Okay. The blood supply of the talus, posterior tibial artery, anterior tibial artery, peroneal artery. Blood supply of the talus. Talus calcaneus. Okay. Posterior tibial artery, anterior tibial artery, and peroneal artery. Blood supply of the talus. Posterior tibial artery, anterior tibial artery, and peroneal artery. Okay. In case of displaced talar neck fracture, which could lead to disruption of the artery of the tarsal canal, most of talar blood will lose its blood supply except medial portion, which supplied by the deltoid branch, and that will lead eventually to avascular necrosis. Okay, you can go for that. Isra. Hello. You can go for iftar. Okay.
Hello?